Today, we're discussing one of the most high-risk scenarios in obstetric anesthesia, the management of a patient with severe mitral stenosis, MS, undergoing a lower segment cesarean section, LSCS. This combination is a classic perfect storm that presents a significant challenge due to the physiological changes of both the high-output state of pregnancy and the dramatic hemodynamic shifts of the surgical procedure itself. Our goal is to outline a safe, evidence-based, and systematic approach to care. As we know, MS is a heart valve disorder where the mitral valve opening narrows, restricting blood flow from the left atrium to the left ventricle. This obstruction creates a crucial physiological bottleneck. This backup of pressure and blood, initially in the left atrium, quickly transmits back to the pulmonary circulation, leading to severe symptoms like dyspnea and eventually, life-threatening pulmonary congestion. Pathophysiology of mitral stenosis. Let's briefly review the mechanics. The normal mitral orifice is quite large, 4 to 6 square centimeters. Symptoms typically develop when the valve area is less than 1.5 square centimeters. That's a critical reduction in flow area. Rheumatic disease is the most common cause, leading to leaflet thickening, calcification, and fusion of the commissures and chordae. The result is a rigid, funnel-shaped valve that restricts passive ventricular filling.
The single most important hemodynamic consequence is the diastolic pressure gradient across the mitral valve. Because the narrowed valve orifice impedes passive LV filling, the left atrial, LA, pressure increases to maintain flow. This high LA pressure then transmits backward to the pulmonary veins, leading directly to pulmonary congestion, or what we see clinically as pulmonary edema. Chronically, this pressure backup causes reactive pulmonary arterial vasoconstriction and structural changes, resulting in pulmonary hypertension, PH. This PH, in turn, overburdens the right ventricle, RV, leading eventually to right-sided heart failure. Finally, the chronically dilated and high-pressure LA is prone to developing atrial fibrillation, AF. AF can cause catastrophic decompensation by eliminating the crucial atrial kick and, more critically, by significantly reducing the already limited diastolic filling time. The physiological changes of pregnancy dramatically worsen MS symptoms. We see a 45% increase in plasma volume, peaking in the second trimester, which increases preload and exacerbates pulmonary congestion. A 40 to 50% increase in cardiac output drives up flow across the fixed, stenotic valve, increasing the transvalvular pressure gradient. Crucially, the increased heart rate, HR, of pregnancy further shortens diastolic filling time, limiting left ventricular preload and cardiac output. Since the stenotic valve flow is time-dependent, the normal pregnancy tachycardia is detrimental. Etiology of mitral stenosis. While rheumatic heart disease remains the overwhelming cause in developing nations, it's important to remember other less common etiologies, including valvular calcification, congenital abnormalities, and autoimmune conditions like systemic lupus erythematosus, SLE. Clinical features. The symptoms are a direct consequence of the underlying pathophysiology, pulmonary congestion and low cardiac output. Patients present with dyspnea, exertional, or the more ominous nocturnal dyspnea, signs of heart failure like cough and edema, and systemic issues like palpitations and fatigue. In a pregnant patient, a sudden worsening of any of these symptoms is a major red flag. On physical exam, we look for mitral facies, the pinkish-purple discoloration of the cheeks, and signs of AF. The classic auscultation triad is key, the loud P2, indicating pulmonary hypertension, the opening snap, OS, and the characteristic low-pitched, rumbling mid-diastolic murmur at the apex. Signs of complications are also critical, including crepitations from pulmonary edema and the RV heave associated with severe pulmonary hypertension. Severity and impact in pregnancy. For anesthetic planning, we must know the severity. The classification is based on the mitral valve area, MVA. Mild MS, MVA greater than 1.5 square centimeters, is usually tolerated well. Moderate MS, MVA 1 to 1.5 square centimeters, will often become symptomatic in pregnancy. Severe MS, MVA 1.0 square centimeters, carries the highest risk, a significant risk of pulmonary edema, heart failure, and death for both mother and fetus. Preconception intervention is ideally recommended for this group. Evaluation. The initial evaluation relies on a careful history and physical exam, paying close attention to the New York Heart Association, NYHA, functional class. Our investigations are categorized into non-invasive and, less commonly in a pregnant patient, invasive studies. Non-invasive studies. The non-invasive workup is standard. The ECG will show signs of left atrial enlargement, the P mitral, and may reveal right ventricular hypertrophy or atrial fibrillation. The chest X-ray can show LA enlargement and signs of pulmonary congestion. The echocardiography, echo, is essential. It confirms the structural changes of the valve and provides critical hemodynamic data. Doppler color flow imaging is what quantifies the severity. It measures the pressure gradient and the definitive valve area, as well as the pulmonary artery pressure. The invasive study, cardiac catheterization, is rarely needed during pregnancy but is the gold standard for definitive hemodynamic data, confirming transvalvular gradients and ruling out coexisting coronary artery disease. Treatment, medical management. The goals of medical management are to control symptoms and optimize hemodynamics. Rate control is the cornerstone of therapy. Beta blockers prolong diastolic filling time, allowing more blood to flow across the stenosed valve and reducing LA pressure. Diuretics are used judiciously for pulmonary congestion, but we must avoid excessive use to prevent maternal hypotension and reduced uterine perfusion. Anticoagulation is essential for patients with AF or a history of thromboembolism, with low molecular weight heparin, LMWH, being the preferred agent in most of pregnancy. Interventional or surgical management. Intervention is indicated for severe MS with limiting symptoms despite maximal medical therapy. Percutaneous mitral commissurotomy, PMC, is the treatment of choice. It's a safer non-surgical option during pregnancy, ideally performed in the second trimester. If the valve is not suitable for PMC or there is severe regurgitation, valve replacement is a possibility, though rarely performed during pregnancy. Management of labor and delivery. The peripartum period is extremely high risk due to rapid shifts in blood volume. Vaginal delivery is generally preferred as it avoids the hemodynamic swings of a C-section. Our hemodynamic goals are vital. We must avoid tachycardia. Using aggressive pain management, like an epidural, is key here. We must also maintain preload and avoid sudden drops in systemic vascular resistance. Finally, the immediate postpartum period is critical. The autotransfusion of blood from the contracting uterus can cause acute volume overload and catastrophic pulmonary edema in this fixed output state. Anesthetic management for LSCS. Preoperative cardiac evaluation, history. Our anesthetic management begins with a meticulous preoperative evaluation. We must assess the patient's functional capacity using the NYHA classification. This is the strongest predictor of periprocedural risk. We also look for current symptoms of congestive cardiac failure, CCF, and conduct a thorough review of all medications, especially rate control agents and anticoagulants. Elective surgery must be postponed until CCF is treated. Physical examination. The physical exam targets signs of decompensation, S3 gallop and crepitations for left-sided failure, and elevated JVP and edema for right-sided failure. We also reconfirm the classic signs of MS and look for signs of digitalis toxicity. Laboratory and imaging evaluation. The essential tests are the ECG for LA enlargement and arrhythmias, the CXR for cardiomegaly and pulmonary edema, and the echocardiography, which is non-negotiable. The echo provides the definitive assessment of valve function, myocardial contractility, and the degree of hemodynamic compromise. Other tests. Other advanced tests, like cardiac catheterization, confirm the degree of transvalvular gradient and pulmonary artery pressure. Organ function and coagulation status must also be checked as part of standard preoperative clearance. Preoperative medication management. The core goal is to optimize medical status and decrease anxiety-induced tachycardia. We continue most cardiac drugs, but a critical decision is the management of anticoagulation. It must be discontinued for major surgery with anticipated blood loss, and neuraxial anesthesia is strictly avoided in the presence of active anticoagulation. Preoperative management, hemodynamic goals. These 6 points are the absolute essence of your anesthetic plan. For MS, the phrase is slow, full, tight. 1. Rate, maintain a slow normal HR, 60 to 80 bpm, to maximize diastolic filling time. 2. Rhythm, maintain sinus rhythm. Treat atrial fibrillation aggressively. 3. Preload/volume, maintain adequate volume. Hypovolemia is poorly tolerated, but excessive fluid leads to pulmonary edema. 4. Afterload, SVR, maintain SVR to prevent hypotension. 5. RV function, avoid anything that increases pH. 6. Avoid triggers, hypoxia, hypercarbia, acidosis, and pain all increase pulmonary vascular resistance, PVR, worsening right heart function. Preoperative and intraoperative considerations. In terms of anesthetic technique, epidural is often preferred over a spinal because the onset of sympathetic blockade is slower, minimizing a precipitous drop in SVR. General anesthesia, GA, is a good choice for very sick patients where minute-to-minute control of BP and fluid is paramount. For drug choice, we avoid ketamine due to its sympathetic stimulation, and use propofol and volatile agents with extreme caution to prevent myocardial depression and vasodilation. If hypotension occurs, phenylephrine is the vasopressor of choice because it avoids the beta-agonist activity that would increase the heart rate, which is our primary enemy. When using neuromuscular blockers, we avoid large boluses of pancuronium due to its vagolytic effect causing tachycardia. For reversal, we use neostigmine with glycopyrrolate to avoid the tachycardia caused by atropine. Monitoring and complication management. For an asymptomatic patient, routine monitoring may suffice. However, for severe MS, invasive monitoring is mandatory. An intraarterial catheter should be placed before induction. Pulmonary artery, PA, catheters and transesophageal echocardiography, TEE, provide real-time, high-fidelity monitoring of left atrial filling pressure and biventricular function, which is invaluable in a critically ill patient. Here is a quick summary of management for key complications. Tachycardia or rapid AF requires immediate treatment with a beta blocker or calcium channel blocker, with a low threshold for cardioversion. Hypotension must be promptly treated with phenylephrine. Finally, for pulmonary HTN/RVF, strict attention to avoiding hypercarbia and hypoxemia is necessary, and you may require pulmonary artery vasodilators. Postoperative management. The immediate postoperative period remains a crisis window. The main goal is to prevent factors that increase PVR and to manage the sudden volume shift. These patients should be managed in a high-acuity setting like the ICU or HDU. We must aggressively avoid hypoxia, hypercarbia, and hypoventilation, as these drastically increase PVR. Continuous hemodynamic monitoring is essential, and aggressive treatment of pain and anxiety is necessary to prevent tachycardia. Analgesia. Effective analgesia is crucial. It decreases the stress response and prevents the PVR increase. Neuroaxial opioids are the preferred choice for superior, long-lasting pain relief. A low dose of intrathecal morphine, e.g., 100 mg, provides excellent, long-lasting analgesia and is highly recommended. For systemic analgesia, non-opioids like NSAIDs and paracetamol are key components for an opioid-sparing effect. Patient-controlled analgesia, PCA, can be used, but it is generally less effective than a well-managed neuraxial technique. To conclude, the anesthetic management of the parturient with mitral stenosis undergoing LSCS hinges entirely on achieving a narrow set of critical hemodynamic goals. MS represents a state of fixed cardiac output, therefore, the core objective is maintaining a low to normal heart rate, 60 to 80 beats/min, and maintaining sinus rhythm to optimize flow across the stenotic valve. The secondary, but essential, goals are maintaining the full and tight state, adequate preload and systemic vascular resistance, while strictly avoiding factors like hypoxemia and acidosis that increase PVR. The immediate postpartum period demands the greatest vigilance due to the abrupt autotransfusion of blood, which can rapidly precipitate pulmonary edema in this delicate, fixed orifice state. Successful management requires a meticulous, multidisciplinary approach, precise titration of vasoactive agents, and a deep commitment to maintaining the patient's hemodynamic balance throughout the perioperative period. Thank you for your time and attention.